So good evening. Thanks for coming. My name is Luis Figueroa, and I serve as a member of the LBJ Future Forum. And on behalf of the Future Forum, thank you all for joining us this evening. Before we begin, I'd like to just share a little bit about the Future Forum for those of you that are unfamiliar. We are an initiative of the LBJ Presidential Library dedicated to fostering bipartisan discussions, networking opportunities, and community events that inspire a higher level of political discourse and community engagement in Austin. Our mission is rooted in President LBJ's favorite Bible verses. Come, let us reason together. Through this, we strive to create civil, informed, and bipartisan discussions. If you are not already a member, I would encourage you to sign up tonight. Members enjoy first access to events and happy hours, networking opportunities, and special perks at the LBJ Library. Our next events include our annual egg roll on the lawn of the LBJ Library, inspired by the White House egg roll, and a conversation on water conservation next month. If you'd like to learn more, please visit our membership table in the back. On tonight's event, the Affordable Care Act was signed into law 15 years ago by President Obama, with the goal of expanding health insurance coverage, reforming the health insurance market, and addressing healthcare costs and quality, fundamentally reshaping American healthcare. According to the Center on Budget and Policy Priorities, the number of people who are uninsured has dropped from 45.2 million in 2013 to 26.4 million in 2022. In addition to reducing the number of people without coverage, the HCA market plans and Medicaid provide far lower cost coverage to millions more people. But despite this progress, there are millions of Americans still without coverage, and the system is far from perfect. This evening, we hope to explore what has worked, what hasn't, and what could be done to address some of the gaps. We have an expert panel joining us this evening, including Dr. Kimberly Avila Edwards, a pediatrician and associate professor in the Department of Pediatrics at Dell Medical School; Philip Eaves, Vice President of Population Health for Ascension, Texas, and the President and CEO of the Ascension Seton Health Alliance; Stacey Pogue, Senior Research Fellow at the Center on Health Insurance Reforms at Georgetown University's McCourt School of Public Policy; and Dr. Patrick Lee, President and CEO of Central Health. Moderating today's discussion is Dr. Pratish Gandhi, President and Founder of Effect Health. Please keep in mind there will be time for questions at the end of the program, but for now, please join me in giving a warm welcome to our speakers.
All right, let's hop in. Really nice to see folks here today. Awesome to be sitting on the same stage with these experts and, frankly, icons in health in Texas and in the country. Just so I understand a little bit of context setting here, can you raise your hand if you work in healthcare or healthcare adjacent? Got it. And then raise your hand if you just care about policy, and that's why you're here and care about health. Right, okay, I got it. Okay, good. The Affordable Care Act is terribly complex, and healthcare is terribly complex. It doesn't need to be, actually. And we're going to dig in today talking about the ACA 15-year anniversary, and we're going to talk about its core goals, which at the time was to expand healthcare coverage, enhance quality, reduce cost, which really led to a fundamental reshaping of American healthcare. Uninsured gained access to coverage, as we just heard, through Medicaid expansion in some states, not all, Texas being one of them. There's creation of a health insurance marketplace. There's protection for those with pre-existing conditions. The number of uninsured dropped precipitously, but there are still millions without coverage, a disproportionate number of kids, like in Texas. And the ACA was never meant to be really the only solution. It was meant to be a framework. But I think on this panel today, we'll have this conversation on, was it actually a framework that dictated how health was supposed to be? Or was it actually the form that was built out of the function of healthcare? And we're going to dig into that theme as we move on in the conversation. So 15 years in, where are we? What have we learned? What's working? Where do we go from here as we stare in the face of a nation and a state with profound burden of chronic disease, with significant inequities in access to healthcare, in health outcomes, by race, by gender, by socioeconomic status, by geography? What does health look like? So let's just hop right in. Happy to be here with you guys. 15 years of the ACA. What is its most significant achievement, and what's its most glaring shortcoming? Stacey, let's start with you.
Well, I would say the ACA framework really had the most probably detailed investment in the coverage piece, and it's been remarkably successful on that front. So its aim was to find folks who were locked out of coverage, who had no pathway to coverage. And it wasn't most people, right? But some people whose job didn't offer coverage, or they were an immigrant, or they worked a low-wage job. They had no pathway to coverage, and it aimed to, and I think pretty successfully, created pathways of guaranteed coverage that was affordable based on your income, and that's an important promise, and had some level of standard to it, some basic level of care that was something like what you get from a large employer. And I think where you have to put the asterisk is whether that was available to everyone. And it's not. But I think the ACA was tested in the first recession we had after it was put in place. It was the COVID recession. There was a really steep drop in employment that was up 15% unemployment, second highest to Great Depression. And we didn't lose coverage. The uninsured rate held steady. And that didn't happen before, right? In the recession before the Great Recession, 60% of everybody losing their job 60% of everybody losing their job-based coverage went uninsured, right? And what we saw when the ACA was tested, when people lost their jobs in the COVID recession, is that they did lose job-based coverage, but then they picked it up through Medicaid or they picked it up through the marketplace. And so the system of coverage, while imperfect, is working on a day-to-day basis and working when we have these big calamities.
If you don't mind, can you talk a little bit more about what that means in a state like Texas? Like, help maybe unpack what the ACA did for Texas, maybe differently in states that expanded Medicaid. What does that look like?
Yeah, so a lot of the ACA went into effect regardless of what your state did. But there were pieces that didn't. And the Medicaid expansion is a really, really important one. As drafted, people below essentially the poverty line, give or take, and below could qualify for Medicaid. But when the Supreme Court reviewed and upheld the ACA, they made that piece optional to states. And our state didn't adopt it. 10 states haven't adopted it. And so it looks really remarkably different here than it would in the other 40 states about what kind of access you have when you lose your job, when your income goes down, you name it. So coverage has improved. We've had coverage gains across the board at every income level, at every race, ethnicity, at every corner of the state, but not to the scale we would have if Texas fully adopted the Affordable Care Act.
Thank you. Phil, we've heard about how coverage has improved, right? We've gotten a record number of folks off the uninsured rolls and into some kind of coverage. Yet there are still questions around, increased coverage, but not necessarily improved care outcomes. Now, a lot of the innovation of the Affordable Care Act was driven through new methods of delivering care, right? Through value-based care. And I want to take a second and maybe first, can you just unpack a little bit around what is value-based care? What is some of the innovation that came out of the ACA? Can you help us understand that, understand about accountable care organizations? Then I'll maybe follow up with another question for you.
Yeah, sure. I'm happy to just explain that. So we live in if I put it this way, 80 years ago, there was a model created. It's called fee-for-service. So essentially, you go into a practice, physician drops codes. There's certain reimbursements for those codes, and that's how the practice gets paid. And, I think the term that people use is that's more or less focused around sick care. When the Affordable Care Act was passed, it really brought front and center something that's been talked about since the 70s, which is value-based care, and really brought that forward. And what value-based care is if you are a physician, you have a panel of patients, and you're being held accountable for controlling the cost and also improving the quality for that panel of patients. And the Affordable Care Act created something called accountable care organizations. And so it put those traditional Medicare lives in something called a ACO, an accountable care organization. And it assigned those lives to primary care physicians primarily. And those physicians had benchmarks So essentially the amount of money that Medicare would say, this patient here, based on their diagnoses and based on some regional benchmarks, should be essentially spending this much in healthcare every year. And the physicians have to essentially beat those benchmarks and get below that in the cost. And then they also have various quality metrics that they're held accountable to as well. And what that's done over time is that's reduced the cost of healthcare for lives that are actually in accountable care organizations.
So I get that. And that sounds important. But in a state like Texas, cardiovascular outcomes have essentially stayed the same, stagnant over the last 15 years. We've had an increase in obesity rates in Texas, and nationally, there are other indicators that have continued to worsen from the clinical outcome side. And still today, most of the money flows through fee-for-service infrastructure. Are we missing something here with value-based care? Is it that we're not adopting enough of it? Is it that the incentives are misaligned? What's the challenge here?
Yeah, so there's multiple challenges. I mean, number one, HCA addresses this for Medicare lives, right? So you've essentially got a little over half of your Medicare lives that are enrolled in Medicare Advantage plans. Those are primarily focused around value. And then you've got the other 49.6%, which are traditional Medicare lives. And only half of those lives are actually enrolled in a value-based accountable care relationship with a physician. So you've still got a good chunk of those traditional fee-for-service Medicare lives that are not participating in this program. And then where I would kind of back up is, Medicare has adopted value-based care. By 2030, they say every Medicare life will be in a value-based relationship. But where value-based care has not been fully implemented is in the commercial space. So think about if you are, you're a child, you go to a pediatrician. Pediatricians primarily focus on prevention, right, at the front end. So they're participating, I would say, in value, but they're not getting paid to really practice value-based care. When you get a little bit older, you get on your employer's health plan. And the employer's health plan, although there are supposedly some value-based models, we participate in quite a few of those. And to be candid with you, they're not structured in a way like Medicare is to really pay doctors to manage populations. And you don't really have much of the support infrastructure like chronic care management, transitional care management, lifestyle management programs that are really deployed for that population. And that's where a lot of those decisions that those individuals make at that point in their life will impact them later on. So when 65 hits, you enroll in a Medicare plan, and all of a sudden you're in a true value-based relationship. By that point, it's kind of managing diseases. And so what I have really pushed for is to not necessarily go in and participate in every value-based program through a Blue Cross, United, Cigna, and Aetna, but to go directly to the employers and take your value-based chassis that you have created for Medicare and deploy that directly with employers and actually build value-based programs directly and to actually impact people's decisions and how they essentially live their lives and make better decisions so when they do get older, they don't have all those chronic diseases and they're not living in a state where we're just trying to maintain them. So I think that is one of the biggest missing components is not value-based care has not been adopted and it's not been successful in the commercial space. And the only way it's going to be successful in the United States is if it's successful there. Because you can do this Medicare thing. I think there's a lot of value in it. We have a lot of positive results through the Seton Accountable Care Organization, which Austin Regional Clinic participates in. But at the end of the day, if they're not managing their health further kind of upstream and making those right decisions, then they get to a state where it's just managing chronic diseases later on in life.
So I want to dig in on this here, and in part of this conversation, we are talking about some of the nuts and bolts of the ACA, but the reality is, in some of what I said earlier, been thinking a lot around form and function and function and form. Undeniably, there's going to be new rounds of reform as it relates to healthcare in this country. And either the reform is going to come and we're going to build health on the back end of that and be dictated by the policy that's passed, or we're going to define health in a certain way and hopefully a policy that supports it. And so one of the things that, what you're saying is resonating with me. It makes me think about, we had a patient at my FQHC where I worked here in East Austin at Peoples. We ran a complex care clinic for folks that really had multiple chronic conditions. And one of the things that we realized, I think fairly early on, was that, and certainly no malintent to my fellow physicians on the panel here, but very little of my patients' outcomes had anything to do with my stethoscope. Very, very little. The reality is that we were able to achieve, I would say, impressive clinical outcomes by building an entire apparatus of care around my patients. So, the patient of mine that had diabetes and heart disease and was morbidly obese, that drove a bus twice a day and worked in construction and drove a forklift in the middle of the day, what was really important in that relationship wasn't us titrating his diabetes medications appropriately. It was actually getting to know his family. It was getting to go and see his ranch in Manor. It was understanding his motivations. And we brought a whole team to bear around that and had an unbelievable turnaround. And he was one of many patients that we were able to do that with. But that's a new way of delivering. That's a new kind of care that may not necessarily put physicians in the driver's seat. It requires new ways of thinking about care delivery and care structures. Pat, you think about this a lot at Central Health. The reality is that we are still very much in a fee-for-service ecosystem. The Affordable Care Act didn't account for the fact that if you're on Medicaid, you may be switching plans regularly. If you're privately insured, you may not stick with your plan for more than a year. How do you even begin to start thinking about care models that are new, that have local accountability? What does that look like? What does integrated care look like for Austin and for Texas now and 5 years from now?
Thanks, Pritesh.
Good luck with that question.
Thank you. It's a softball question, and colleagues and everyone, thank you for the opportunity to be together. I love that question. I want to amplify a couple of things I've heard and just weave this together briefly, if I may. So, Phil, you talked about the notion that we can pay for the pieces of care in a fee-for-service way within the clinical encounter, or more broadly in how we create the medications and who makes money off that, how we provide insurance and coverage, who makes money off pooling the risk and so on. But essentially a system in which parts of the whole care system are potentially profitable and very large, very important parts are not, right? And that's in some ways what value-based care is trying to solve for. But when we have a predominantly, we pay for parts of this journey, what we end up with then is islands of care. We have islands of care separated by, deep running water. And if you have resources, people, you can travel to a different city, you can take time off work, you might be able to make this work. There's actually very few of us for whom this works great, actually, even if we have commercial private insurance and resources. And if you don't have those things, you don't have insurance, maybe it's not your first language, you don't have a stable income, maybe you feel unsafe for one of various reasons, it becomes enormously complicated, it even becomes deadly. So we know here in Austin, Travis County, on average, if your zip code puts you east of I-35, east of where we are today, on average, your life expectancy is 10 years lower than if your zip code is west of I-35. That's a pretty profound thing in our small, big town. And if you zero in on the areas of sharpest difference, you might see a 20 to 25-year difference in life expectancy where geography is destiny in our own small, big town. And that's actually a problem we can trace back to this problem of deep fragmentation. And then the prescription then is the opposite of fragmentation. What if we put that all together? What if the central principle is patience, people? Right? What does it take to earn your trust? With that trust, what does it take to understand what you need and want to thrive today and potentially over time, because things may change over time? And then what is required to then bring what you need to bear so that you can thrive today and over time. One size fits one, not necessarily one size fits all. There are some solutions that will work for populations of patients. And at the end of the spectrum that you mentioned, Pritesh, with the patients that you cared for at Peoples and that we care for at Central Health, there are definitely patients for whom one size is not going to work for all. And we have to meet people where they are. That requires doing things that are largely not going to be profitable. They're not going to be attractive to for-profit companies or private equity. There's going to be no sort of impatient capital, multiple return investment. It requires, sums of investment and time horizons that are going to be very difficult for nonprofits to take on in a way that is sustainable and reasonable. And so what are we left with then? I think one of the things that I'm really interested in, and I know we've talked a lot about, Pritesh, is what about local government? Right? What about the notion that we have a duty, an accountability, a passion, and a connectedness to work together with all the different components of local government and community-based organizations and major health systems to be a bit of a glue at Central Health to put your tax dollars to work, to say, let's imagine somebody who has longstanding serious mental illness, has one or more substance use disorders and addictions, has been chronically homeless, has been arrested, incarcerated multiple times, has been in the emergency department hospital multiple times, right? What will it take to create a program to meet that person where they are? And if we do that effectively, would we reduce the need for hospitalization, for police and jail systems, for perhaps the effect on our economic environment to have a lot of folks who need care wandering around Congress Ave, patently not getting the care they need when others are coming to our fair city to decide if they want to set up shop here. Right? How does that work? We might actually invest upstream in this problem and generate a lot of value downstream in this problem and really wrap the care that people need around that individual's needs. And there's a lot behind what it would take to do that and how we would articulate what the return on investment is for the community, in that way. Not necessarily shareholder value, but lives saved and the value of lives saved, economic productivity created and the value of that, avoided medical expense, regardless of whose bottom line that lands on. Ultimately, the public pays the cost. And so what about local government?
So, you've raised a lot of points here, one of which is this notion of trust. If I can maybe take a second and think through, at times, the unbelievable instant gratification that government operates under. Many years ago, there was, I think in the 70s, a study, I may be getting university wrong, I think Chicago, but they did it in schools, I believe in North Carolina, where they were looking at the investment of the utilization of early childhood education, right? So what they did is that they put kids in early childhood, super high quality early childhood education, did it for, X number of years, and then put these same students back in sort of mainstream public school from kindergarten onwards. In students that had that exposure to the preschool intervention that was high quality, even after being in public school in maybe a resource poor setting, when they compared those students to those students that didn't have access to that early childhood education, the outcomes were significant and they lasted decades. reductions in teen pregnancy, improvement in high school graduation rate, reduction in chronic disease, reduction in suicide, increased chance of going to college, increased chance of keeping a job, reduction in substance abuse. I mean, the list is unbelievably long, and all it took was this tiny investment early on, but this desire to play the long game. But we're operating in an environment historically around the sort of instant gratification, and now in an environment of disinformation and malinformation and misinformation and a lack of trust. Kim, you're the resident pediatrician here on this panel. You're an icon in the care of children in this state. You have worked with kids and families in all parts of this city. The ACA was incredible in its mandates for well child checks and preventative screening and immunizations. But now we're working in an environment where a second child has died of measles. Trust is at an all-time low. What happens here? How do you even leverage what the ACA has afforded when you're dealing with this entire environment?
Such a great question. Thank you for that. And good evening, everyone. Thanks so much for the opportunity to be here. We were talking just before we came on of what gives us hope. And listening to your all's answers gives me such hope because you are leaders in this community and you speak just about the healthcare world as it should be, and it's rejuvenating. So thank you for that. So I've been here in Austin for almost 25 years as a general pediatrician, and it is my greatest joy to serve children and their families. I think the biggest change I've seen over the last 25 years is this conflict. And just to level set a little bit, misinformation is inaccurate or false information that is spread without any intent to deceive. Disinformation is false information that's kind of purposely created and spread to deceive others. And then malinformation is information that's based in truth but is used to harm or to mistreat others. So just wanted to level set that. That has been probably the biggest change that I've seen in my 25 years of career. And whenever I think about an issue, I always think of what we call the socio-ecological model. For those of you who may not be in healthcare, what it involves is really thinking about the center of a concentric circles being, for me, children or the patient, and then thinking about all the influences on that child's health and how we can influence it. So when you talk about misinformation and disinformation, the first concentric circle outside of the child is the family. And when you, Dr. Lee, said meet families where they're at, that is absolutely a truth of how you combat misinformation. To partner with them. One of the things I always tell my patients is, I am here to be your partner. You know your child best, and if anybody ever makes you feel different, you are in the wrong place. So partnering with families, having that shared decision-making, listening, because if I was a parent in the social media-rich world, I would have a hard time just disentangling what is true, what is not true. I would be worried. And the Kaiser Family Foundation just had a survey in January of this year that asked, who do you trust most? And still on that first rung of who is most trusted are physicians. So really embracing and valuing that partnership. You know, we talked about Medicaid and the ACA, and one of the ways that it has served children is that it did expand Medicaid for children, in that when the ACA came out, it level set so that everyone, because states were doing things differently, it set the national standard, and correct me if I'm wrong, Stacey, but 138% and below the poverty level is where all children automatically qualified for Medicaid. So we saw improvements in that. And to your point, that yes, there have since it's a federal and state program, federal statute tells us I should do this at a well check, this at a well check. It's been in partnership with the American Academy of Pediatrics. I couldn't be more grateful for the opportunity to do immunizations, to talk about anticipatory care, to look at that upstream prevention that is the core of pediatrics. And when we think about value, which I would further define as the outcomes that are most important for patients divided by the cost of care. And when you think about value and the return on investment, there can be no pediatrics is very unique in its value proposition. The return on investment is so high. If we invested more in children, and what we have seen in Medicaid studies is that having Medicaid give access to that high quality, comprehensive care that it allows, we have seen improvements in timely access to care, to your point, to reductions in infant and child mortality, reductions in ER visits, reductions in maybe avoidable hospitalization, and long-term improved high school graduation rates, improvement in college enrollment, and even an adult's wage earning potential. So there are such long-term benefits. But going back to those concentric circles, what is so valuable is having that partnership with parents. But if they can't come in to see me because we have issues with eligibility and enrollment, in Texas, when I first started my practice here, families on Medicaid had to enroll 4 times a year and show that they were eligible for that. We improved to every 6 months, and now thanks to federal statute, it's for 12 months children are enrolled.
It's not long enough. It's not even close to long enough.
And I was going to say, let's look at examples like Oregon that are 6 years. Even further, let's make it 26 years that is continuous eligibility. Let's make children automatically enrolled in Medicaid when they're born. And if you have private insurance, then that will override that. But investing in children is so important. Coverage. So even though there are dictates that say what I should do at well checks, the government oversight of that has been woefully robust, so that we don't know if all kids are getting that. And then when I think about payment and finance, I think there's been a just persistent undervaluing of children's health care. When you think about what is paid for children's health care, it's woefully below commercial insurance, and it's also woefully below Medicare. So let's make it equitable, because investing in children today will make our workforce, will make our adults healthier in the years to come.
So how do we do this? There's a part of me that gets angry. I'm angry. I'm trying not to be angry. I have to summon Pat's calmness. The challenge is that we've talked about value-based care. We've talked about playing the long game. We've talked about sort of automated enrollment upon birth. Talked about local accountability and local government. It feels that the ACA was this really important thing that helped us knock out all of these initial items. But honestly, in the practice of medicine and looking at the outcomes in our country, it's like the bare minimum of what needs to happen. Because the reality is, and I've talked often to colleagues here on the panel and elsewhere, I've had the opportunity over the last decade to go all over this country. We got to take care of patients in East Austin who were uninsured or underinsured, and in some prior roles have visited most rural areas in this country. And the Surgeon General was right when he said there's a loneliness crisis. Like, if you're seeking to understand the world we're in, like, go visit the middle parts of this country and talk to people in their homes. And it is so painful. It's a visceral conversation where, and I'm trying to think about the family that I had opportunity to visit with the dean of the West Virginia School of Medicine. And we walked into this room in an RV, and the loneliness and the fear, people are, and I say loneliness twice or 3 times because people are alone in their journeys. They're alone. They don't know how to pay for their health care, and they're dealing with substances and a host of other challenges. So we've got these monumental tasks ahead of us. There are bright spots. Health systems like Kaiser, some of you may be familiar with the Kaiser system, they're able to make unbelievable investments in education in social determinants of health. These are all the factors outside of just healthcare that influence health outcomes, like housing and education, other things. They're able to make investments in housing. They're making investments in food as medicine. But they're able to do those things because the Kaiser system, once you're in it, you're in it. And they deliver care, and they're also the health insurance plan, and they also own the hospitals, and they own the specialists, and they're doing primary care. So they have an incentive to actually play the long game. If you had like a blank slate or a piece of paper that could tell policymakers what to do with the ACA, what do? What's phase 2 here to start to lean in on long-term value-based care, on some of these innovative models of care that we've heard here on the panel today?
So I think for me, my observation is that I feel like we've been running in place for most of the history of the ACA, just trying to defend and explain what is there and not talk about what's next, right? It is a law that was written in 2007, 8, 9, right? And when we talked about prevention, then we meant mammograms and colonoscopies and vaccines, and those are important. But we weren't talking about early childhood education investments, right? We weren't talking about social determinants of health. And the fact that we are still relitigating, right, whether low-wage working adults deserve access to coverage, and the answer in Texas is no. And in other states, it might be yes, but it might be that they have to work and document that they work and fill that out on a system, monthly or quarterly or annually to keep that coverage, right? So we're still having these conversations about under what terms do other people deserve that financial access to health care. And it prevents us from having the other conversations where we need to be moving on to, right? So I hope we get to move on to those conversations at the policy level. I think affordability needs to be revisited. It needs to continually be addressed, right? We can't say the Affordable Care Act passed and that's done and not be able to have a conversation again about affordability for 15 years or 20 years. Can I
ask real quick, what is the way to address the affordability issue? It's top of my mind today. We took my middle kid, God bless her, broke her finger playing basketball. I incidentally tore my ligaments playing in January, so we're a hot mess playing basketball in our family. But we went and paid the specialist copay, which was significant, and then got estimates for what will be the copays for physical therapy before we hit our deductible. And this is a physician household, and these are steep. These are the same copays, deductibles that colleagues of mine who are on the same health plan who are not physicians face. Like, what does that look like, actually?
I think affordability, I think we got to count out from two sides. And one is the public investment subsidy side, right? Like Medicaid, people, at least in Texas, don't have to pay premiums to enroll in that coverage. They don't pay, copays at the doctor's office, right? It's calibrated for the very low-income population it serves. And the marketplace has some graduations in that, right? Like you do pay some premiums if you've got a middle income. You do pay some copays, you pay some deductibles. And in some cases, at higher incomes, they're frankly too much, right? So we have the piece that's supposed to protect people at the point of service or at the premiums, but that works in Medicaid, a little bit in Medicare, works in the ACA a little bit. It doesn't work in job-based insurance. There's really not an infrastructure like that. And half of everybody has job-based insurance. And we don't have a way for our employers to say, and not very many have stepped up to say, I'll make sure my low-wage employees pay less, right? And that their co-pays are less, and that they can get the value-based care, and they can get the wraparound services, right? Because you will be discouraged from getting the care you need if the insurance you have, if it's $50 or $100 to see a specialist, and you've got to go again and again. So that's on the personal side. But besides that, we have to work on the actual cost of healthcare. So, and then probably everybody knows this or has heard that we pay twice as much per person for healthcare in this country than other Western, high-income, wealthy nations, and we don't have better outcomes. And any economist will tell you that is not because we use more healthcare. We're not going to the hospital more, the doctor more on average, in aggregate, but we pay more the unit price of each thing. We're paying more for, right? And it's part of it's that not moving to value-based models, not having incentives that drive down those costs. But we'll have the ACA didn't even I wouldn't say touch the price piece, because politically the authors needed everybody on board, the AMA, the hospitals, the doctors, pharma, right? And when we start going after prices, you start losing a lot of political constituency, because everything, any dollar you claw back, even if you think it's waste, is somebody's income, right? And it becomes much harder politically to go after prices. And I don't have the solution for it, but political will is part of what's lacking.
Okay, I get that. You mentioned a little bit about small businesses there, and Phil, we're in a small business state in Texas. There's always been this gap, right? And small business owners want to do better by their employers, by their employees. What's changed over the last few years as a result of ACA, and what's the future hold for small businesses here in Texas?
Yeah, so what I would say about that is, the number one challenge that businesses in general deal with when it comes to healthcare is just cost. So their costs are going up 6 to 7% every year, which is getting to a point it's not affordable. Many employers have, over the years, shifted costs to their employees. And all that does is just they just don't go to the doctor as often, which creates other issues. I've seen just a lot of employers across the U.S. and especially in the state of Texas start to drive more innovation within healthcare. I've seen this in Houston when I lived there. A lot of the larger employers that were self-funded would start thinking outside of the box. Many times they would partner with providers, physician groups directly. I think that's when you started seeing more direct primary care, for example, making it free for patients, for their employees, family members to receive primary care, because about 70% of your care could be provided in a primary care office, right? Get them engaged in prevention. Also, you see a lot of employers start providing services, like a lot of more wraparound services. So, for example, I'll tell you, when I was in Houston, Southwest Airlines, we put nurses inside their large call centers because that was the largest population that drove most, or the population that drove most of their healthcare spend. Because they were sitting on the phone for 12 hours, they were eating, food that they shouldn't be eating. They were drinking soft drinks all day. And we would have people go in and help them change those, I guess, those things that they did to really help them change that lifestyle. And a lot of that is one-on-one coaching. So you see a lot more programs like that. You also see some employers frustrated with cost have moved towards reference-based pricing. So they're going in and trying to pay health systems a percentage of Medicare. The challenge with that is that does not meet the cost of providing care within hospitals. So there's struggles there. You've also seen a lot of level funding. So a lot of small employers that were self-insured, fully insured, have moved to level funded plans. So that's a plan that's sitting between self-insured and fully insured, and they essentially pay directly just part of their cost, and then they have stop loss that hits. But it's kind of an entry level into self-funding. Transparent PBMs, a huge chunk of healthcare cost is pharmacy. Pharmacy benefit managers are making a killing on drugs and just the markup and this rebate game that we play. So you see transparent PBMs that are going into employers and charging just a PMPM per member per month. This is your flat cost, and then we will charge you the wholesale price for a drug. There's just a lot of movement in the employer space. I would say employers are driving a lot of innovation, which is great. And then you have certain health systems, Ascension being one of them, who partner directly with employers. We do that in this city here and try to manage their populations. And so that's some of what's happening, but and then there's a lot of employers that are getting involved more in policy as well. If you look at who's most profitable in healthcare at the moment, by the way, there are many stakeholders in healthcare. There's just so many different organizations that get a piece of the pie. But the most profitable organizations at this moment are the insurance carriers. And that's a fact. And so, hospitals have to be paid appropriately to keep their doors open. It's expensive to provide care. Physicians have to be paid appropriately in order to keep their doors open. So, I think it's challenging, but I think if we could eliminate some of the stakeholders across the complexity of the system that we build, I think that would cut out some of the waste as well.
Phil, you're talking about hospitals needing to stay open, but you are seeing a trend over the last number of years of pediatric hospitals closing because it's just hard to be sustainable. And you've seen that in major cities, you've seen that in rural areas. Where I practice residency, the Peds hospital closed at Tulane and merged with LSU. It's a great facility, but there are these mergers that are happening. And so you've got this affecting the pediatric landscape. You've got continued increase in childhood obesity. You have still a disproportionate number of uninsured children in the state like Texas. And so in the face of all of that, Kim, as we start to think around what potential reform looks like in any new policy proposal, what do you need to do to start to address some of this in children here?
To your point about the decrease in pediatric hospitals, pediatric wards, I think the issues that we have to really address there are workforce. This 2 years ago, we had the lowest number of medical students going into pediatrics.
Did not know that.
And it's this year it improved, but it really is because I think of that undervalue of pediatric care that I mentioned. I had the fortune to be one of the authors on the first ever clinical practice guideline for pediatric obesity from the American Academy of Pediatrics in 23. And what I loved about that, we finally had a practice guideline because it took 15 years to get the data and have evidence-based guidelines. But we first and foremost said, you have to treat the whole child. And we've referred to this over and over again on this panel. But when you think of a person, really what I do in my clinic just makes up 20% of their healthcare. The rest has to do with health behaviors, drugs, sleep, alcohol. It has to do with the built environment. And it has to do with socioeconomic issues, employment, education. And so when we talked about that whole child approach, it was critically asking questions about that 80%, because we know that 80% defines which kids are going to be more at risk. We tend to always aggregate by race and ethnicity, but it's more, those differences are based on the 80% of healthcare that actually influences a child's health. And it also will determine who has access to treatment. What are the barriers to treatment when we talk about childhood obesity? So recognizing the 80%, we talked about investing in social drivers of health, but paying physicians to ask about them, partnering with our community partners to get those community resources to not just ask about that 80%, but to be able to, in real time, provide community resources to be able to ensure closed loop referrals, which we are doing a number of studies in with my pediatric advocacy group on how does that look? Who do you need to partner with? How do we...
What's a closed loop referral? Can you...
Yes, so closed loop referral means that if I know someone is food insecure, which is a risk factor for obesity, I might refer them to the Central Texas Food Bank, but I need to know that they got the notice that my patient needs help and that my patients were able to go and get help and that it has benefited them. That takes conversations. That takes that community-based organization to be a part of healthcare. And I think that is a must if we are going to invest upstream, if we are going to invest early in life, addressing that 80% and recognizing it as a fundamental part of what my role and responsibility is as a physician, to raise awareness, to ask those questions, and to provide those resources is a must.
So is this how we start to address this issue of profound health inequities in our communities? I mean, because the vantage point where I sit is that, let's take Austin, for example. You have I think a 3x higher Black maternal mortality rate in Central Texas right? When you look at food insecurity, Pat, you mentioned earlier between west of 35, east of 35, for as long as I've been in Austin, you've got 2 and 3X's increase in food insecurity if you're a Hispanic child, if you're a Black child, compared to if you're a white or Asian child. You mentioned earlier about zip codes. I remember when I was practicing in New Orleans, I practiced in a zip code where if you were a Black man born in that zip code, you had nearly a 35-year decrease in life expectancy. And if you walked, compared to a gentleman, if you walked just 1.5 miles north to, I think it was called the Lakeview section of New Orleans. And so just these huge disparities. And, Pat, you mentioned earlier sort of realigning economic incentives. But maybe if you could take a beat and just talk a little bit more about health equity and what needs to change to start to address these profoundly different outcomes by race, ethnicity, geography, socioeconomic status. It's a huge question, and I think a lot of us struggle with this. I mean, what is the policy instrument there? Is it a policy instrument? Is it? I'm asking you many questions in a row. Is it the policy instrument? Is it a changing of the care model? Is it an investment in, education, or like what is it? All of the above, none of the above. How do you tackle something like that?
I feel like you saved the easiest questions for me, Pritesh. I appreciate that.
Yep. You have 4 minutes.
Okay. Thank you. Are you starting at the clock? Just going to anchor back to what I shared a few minutes ago. The diagnosis is fragmentation. We break up where the resources come from. We break up how we pay for care. We break up how we deliver care. We break up the journey of care. We cut off those relationships to restart again, tell the story again. And that is both very harmful. It's also very costly. It's bankrupting our country and delivering the worst outcomes amongst all industrialized nations in the world. It's not working. Right? So let's just talk about what we want to accomplish. We want to earn trust by meeting people where they are. There's a lot to that. It depends on who you are and what it takes to earn your trust in a way that you feel safe, you're willing to engage. Whole person care, that's the 20% of clinical care and the 80% of everything else that you need to thrive. Because that's also cost-effective, healthy, kind, earns more trust, what you want. Do that for everybody and tailor that care one size fits one, especially if you're vulnerable. The more vulnerable you are, the higher the risk, the higher the cost for everybody. Can we be flexible and tailor that care? Okay, easier said than done, right? So that's where it's setting out to do at Central Health. There's a lot of work ahead of us. What's that take, right? So now you've got to put the care team together where the entire team who knows about the 20% of clinical care, including, by the way, behavioral health, addictions care, the integration of mental health and physical health, all these things that also get fragmented within the care environment, and the folks who know about the 80% of what else you need. Coverage, housing, transportation, food, faith, creative services, a place to store your pet if you're going to come inside, all these things that you actually need. You got to put those folks together in an environment where they can thrive. That means we have to have a place where we align the incentives, where if you do the right thing to face people meet what they are, deliver whole person care, you're successful together. And that might include different forms of payment, insurance, and so on. So how do you align the incentives? And behind that, you have to acknowledge that there are huge pieces of this journey, this patient journey, that are missing, that we just have underinvested in for decades or longer. And if we're going to rebuild some of those, we need someone who's going to pay for that. It's not going to come from private equity. It's not going to come from nonprofits. I think that is the role of government. As I said earlier, Central Health has embarked on a first step of that. $700 million plus over 7 years to meet data-driven gaps and community needs that we heard about over years. We heard about those needs. We saved for years. We're 1.5 years into actually spending against those problems. So I'm just going to lift up as a flag. It won't solve all problems, but I think Texas has found part of the answer for urban areas that are growing, like Austin, like Dallas, Houston. These are strong, vibrant tax bases, residential and commercial tax base combined. There's a link between the prosperity of those urban areas and the statutory requirement that we have, that our sister districts have at Parkland, Harris, University Health, JPS, El Paso, and so on. These are all sister districts that have the statutory responsibility here in Texas to translate the prosperity of that property value into the full spectrum resources of care that people need, especially when they're vulnerable. So to think about that problem, I think there's something quite special that we've solved for here, which we should think about. And then maybe other urban areas around the country that have similar problems that might find value in this, better use of funds. I want to bring that home at a much more personal level. So what does that mean locally? A few years ago, it was unfortunately quite common that if you were chronically homeless in that sort of cold snap week, around MLK week, and you were outside, you might experience frostbite. You might end up with the need for an amputation. After your limb had been amputated, you might be discharged back to the street to die. Right? That was just unfortunately the case. Today, that individual will actually be picked up by Austin Travis County EMS. They'll be held overnight, knowing that our Bridge Mobile Clinic at Capitol Plaza, a little north of here, maybe 8 minutes north of here, will be open at 7 a.m. Consistently, there are multiple EMS vehicles parked outside that facility at 7 a.m. Individuals who our colleagues at EMS will say have nothing, right? They don't have a home. They don't have any care providers. They may not even have shoes. They will drop them off at 7 a.m. on a doorstep with all their limbs intact because they've been held overnight, and then EMS can move on. And our team will conduct a 3 to 8 hour visit. The first step of the visit, let's get you something to eat. Let's soak your feet, give you a place to rest. Let's get you your MAP card. You didn't walk in with one, you walk out with one that's live. Let's get you to see a nutritionist, a primary care doctor, wound care, infection control. If we need to get you a rolling walker or a boot or anything that's all on site, we can provide all of that with no referrals, no appointments, in a single visit. And tonight, if we can't get you in a local shelter, we'll get you to a hotel, we'll pay for that, we'll bring you a care package. Soap, socks, underwear, we'll see you in the morning. We may see you 3 to 7 times over the first 2 weeks until we've addressed all of your needs. And then we're gonna tuck you in with community care and primary care, and maybe integral care for behavioral health, for long-term care after we've addressed that sort of big hot mess of things that if we left you on your own out there drowning between those islands of care, it was just not going to work. We know from ECHO's data that that individual will die 10 to 20 years before their time. The moment we get our arms around them, earn trust, never let them go, all the way to housing and care in partnership with the city and the county, ECHO, foundation communities, Mobile Loaves and Fishes, and so on. One unbroken connection around that patient, we save 10 years of life, at least, from the ECHO data. Health economists will put a value on that, between $50,000 and $90,000 per year of life. Let's call it 50. That's $500,000, right, dollars right there that we have potentially saved. I can tell you it costs less than $500,000 to open our doors and put our arms around the individual and never let them go. Now, we are going to invest more of your tax dollars upstream against that problem and do the right thing and save our community a whole lot of money. And I think that's part of the solution. We have to just work differently, start with the person, work out from there, and acknowledge that we have to align those payer incentives, and we're going to have to find someone to pay for building all those huge blocks of missing infrastructure that just aren't there. We can't shy away from how much work there is to do to rebuild that broken infrastructure.
I mean, part of what I think we were hoping to achieve here was to talk a bit about the ACA and talk a lot about what needs to happen next. I've been screwing up the form function analogy for like 2 decades now. I'm not going to try a third time in this conversation to get it right, so I'm going to scratch that. But what I would say is that I've read over the years a lot around principles around serving the poor and disenfranchised and uninsured One of the quotes for decades that has stood out to me that I actually do get right is a quote from Father Gustavo Gutierrez, who he said many years ago. He said something to the effect of, when I give food to the poor and hungry, they call me a saint. And when I ask why they are poor and hungry, they call me a communist, which I think is a fascinating framework. I think part of this conversation today, and has made me think about this in reflection, is you've heard loud and clear from this panel, many of whom are practicing physicians, folks that run large enterprises, folks that think hard on the policy side, the real importance for integrated care. That's a reimagining of care. Care that's not fragmented. Care that invests outside of just the physician-led apparatus, and the need to develop financing models, payment mechanisms to move this country in that direction. And so there's work to be done for the Affordable Care Act. I think, Stacey, as you said earlier, I mean, this was the first act here, and let's see if we can move to this next phase of reform. So thanks for having us. I think we have time for questions.
Why is it that other countries similar to us have much less fragmentation? Excuse me, much less fragmented systems than we do?
Let's take a swing. I'm happy to take a swing at it. I'll say that there is, I think it goes without being said, there is a different value on the social network in other countries. Just is. Whether you're looking at examples from Europe or East Asia, the payment models look different, and the payment models look different because there are different investments in this larger social safety net. And to me, that is example number one. It's the investment in the social safety net that has just been lacking for decades in this country. And where I mentioned earlier the station about early childhood education, you can take that and apply that to many other examples. But I think, to me, it's the lack of investment in early childhood, in the social safety net to start. I don't know if there are other thoughts from the folks here.
The only thing I would add to that, I mean, I mentioned earlier there are so many different stakeholders in healthcare, right? And you've got to take a step back and think like what exactly motivates them. Like we mentioned private equity, right? Private equity is obviously, they're trying to get a return. I think for-profit organizations, you're held accountable to your shareholders. And the reality is, like, all of that doesn't work together. And I think the more of a simple system where you can put the patient at the center of that, and the patient's front and center, and do the best for that individual life, that's what needs to be done. And unfortunately, in the United States, like, we don't have a system like that. I think there are components of it, but ultimately, it's not a system that's cohesive and works together, and the patient is not always number one in that situation because there are so many different interests that are driving those stakeholders.
There probably is another panel that will need to be titled Medicare for All, yes or no, right? Like, there's a question here on that. I mean, I think to Phil's point, every single cent of the healthcare dollar is viciously fought after. Every cent. Every day there are 100 new companies coming out of Silicon Valley and Austin with the next solution. There are PBMs, as Phil said. The landscape is so vicious. It's just vicious, and it feels visceral to me. I've practiced in the federally qualified health center setting for many years. I also practiced at Walmart. And in the federal government. I've had multiple angles of healthcare over these years. Every penny is fought after. And while that may at times lead to unbelievable innovations in care, and I think the United States is still gold standard for top-level diagnostics, it leaves a huge chunk of the population behind. Sorry.
Yeah, I could briefly add a couple thoughts. At first, care is fragmented around the world, depending on the country. It's definitely not perfect out there. So, this is a general problem. It's a very complicated network to put together. When you look at where we spend the dollar, for any given dollar, how much is spent on clinical care, how much is spent on the things that we know are upstream that have a bigger effect for the longer term, we are exactly upside down compared to the world. We spend the vast majority on downstream clinical care, on sick care, if you will, and a pittance on prevention. So that's a problem. And then part of it is a time horizon issue. So I think we're not making the investments that actually have been clearly demonstrated to yield many multiples of return on investment if we're willing to wait 20 years, 25 years.
Gotta wait.
You gotta wait, right? Now we do a lot of things that, we have kids, goodness knows, right? I mean, we're looking at the long term, but we don't drive our policy with a longer time horizon for various reasons. And then fundamentally, I don't think we all agree that everyone deserves a right to health. And so that has to be said. I think some other countries feel differently about that.
To your point about being patient and waiting, I think the current risks that we're seeing with cuts to Medicaid based on budget resolutions that have passed at a federal level speaks to that. So couldn't agree with you more.
It's the right to health, the access to it, but also the right to thrive.
Yeah.
Right? Access is just, we've solved this much of the tiniest part of the iceberg. Other questions?
Hi there. Thank you so much for being here. I just had a question about going back to kind of social determinants of health. And, we know that the Medicaid member is also the student at the school district, is also the patient at the FQHC. So I'm just wondering how you all think about zooming out from healthcare and really thinking about how you work together with all these other systems. Because it really seems like we're asking healthcare to do a lot and to solve a lot. We're asking nonprofits to bear the weight of a lot of this as well. And so I'm just wondering, if we feed that child the FQHC benefits, the Medicaid benefits, the school outcomes are better. And so how do we think about working at the systems level, both informally, but also policy-wise? I know there's, efforts to make traction with policy, pathways for reimbursement for some of these social determinants of health. But in states like Texas, that's not going to happen anytime soon. And so I'm just wondering thoughts on zooming out a little bit and really trying to think about this at the systems level.
I will start and say thank you for that question and thank you for the way that you're thinking. I applaud that. I think you're right. We are still a volume-based healthcare system. So when I'm in my clinic, I see 30 patients a day, and there's no way that I have time for that. And as we've done work around social drivers of health within pediatrics, what we have heard from parents is, oh gosh, I'm getting asked the same questions in the hospital that I was asked in the school, that I was asked when I tried to re-enroll for Medicaid. And I think the lack of ability to have health information exchanges, or all of us having the same access to the information on that one child who is a student, who is a patient, who is, the beneficiary of one of our community organizations, is a huge barrier. And I think we need to find that out, because to your point, for me to know, and examples of that are working well when it comes to pediatric mental health, we do not have enough providers. As a pediatrician, I went into pediatrics, not psychiatry, but I do a large portion of my practice focused now on psychiatry, some days 50%. But at the same time, I can't do it all. And to know that I have access and I have communication with state programs like TCHAT, the telehealth, children's health access through telehealth for mental health within the schools, for me to get a note from that piece of the puzzle. So they do mental health services through the schools. And for me to have that knowledge and say, oh gosh, this kiddo who is coming in this week, who I had no idea was suffering with these issues, I now can address them in a more efficient and effective manner, is so tremendously helpful. So I think we need to think about how to break down those barriers and the communication and all the continuous information that we're gathering, but we're not sharing. So thank you for that question.
Ella? It's been a while. Good to see you. The lights are here, so I said that with a question mark just to cover myself. I don't know who leads here. I'm very confused. I know less about healthcare 20 years into healthcare than I did 20 years ago. I remember a number of years ago, we were very committed, working on a project with Dell Med and others, and very committed to bringing other industries, other folks around the tables. We're working on pediatric asthma, right? And so we brought, I think ABC Pest Control came to a meeting, and they matter because cockroaches in apartment buildings and, cause asthmatic reactions, et cetera. We brought apartment builders and home builders because homes that are put up right next to the highway, has a much higher chance of having children who develop problems with asthma. If you're within 0.2 miles of a highway, the exposure to, 2.5 ppm is much higher, whatever it may be. We brought schools to the conversation as we were talking about where schools were being built. We brought public works folks to the conversation as we were looking at the overall piping infrastructure of the city and making sure we weren't dealing with the same challenges that happen in Flint and with lead pipes, et cetera. You've heard here from this panel a lot about the broad perspective around what it means to be healthy in this country. I don't know the answer. The reality is that right now, the money goes to healthcare. And where the money goes, that's where the conversations sort of live. I don't know how to upend that, and I don't know who leads moving forward. But you're right about the need to have all of those other sectors at the table. The reality is that the root cause for chronic disease in our country starts with food, right? And what's the role of the USDA and food manufacturers and large ag industry in these conversations, right?
Could I pick up on that trail? So it is true that where the money is where folks are going to go. So we do need to understand, how do you build an organization that benefits financially, sees its core economic mission as actually connecting all the dots and delivering the long-term value. So that is a problem to be solved. At Central Health, we see our role that way. So we have part of why I'm so thrilled to be here, that we get to actually solve for that problem. So once you know that you own the long-term problem for the population, then partnership makes complete sense. We talk at Central Health around, we are strongest when we are one trunk, many branches. Health is central, but there's so many aspects of it. We're not food experts. We're not housing experts. We're not transportation experts, but our patients need all these things. So how do we work together? Just a couple small examples. Because of who we are and how we see the world and what our job is, we've evolved a Central Health Equity Policy Council that has kind of leading voices from across this sort of community-based organizations, social stakeholders, and leaders who have developed a kind of a wonderful collaborative process of focus, where every 1 to several years, multiple ideas are brought forward and vetted together to pick one focus area that everyone's going to drive around so that we can actually get traction and stick with it. One of these areas was to make sure that there was opt-out HIV screening. Many of our sites sort of opt in, and I'll get the exact numbers wrong, but something like a 67% increase in actual HIV screening and early diagnosis compared to national suddenly became a best practice. Just this year, that team came together and actually selected food insecurity and the connection to clinical outcomes as the major focus. So now there is a series of requests for proposals, internal micro grants, just many different things focusing on this issue, the connectivity, food pharmacies and so on, looking at who we can partner with to do that. So there's ways that we can connect, things like these policy councils. And then to the point of education, there is, one of my closest new friends in the community is Russell Lowry Hart, the chancellor at Austin Community College. And he has shared with our board, has shared with us that I think the median student at ACC is a single mother of color with between 1 and 2 children holding down 2 to 3 part-time jobs. That sounds a lot like our patients, right? And we know that we serve the same community, and we've worked with ACC to develop pathways for medical assistants. We've graduated 4 cohorts of medical assistants. Students who've come through ACC, they're the lucky ones whose families were able to support these individuals to actually enroll. We know there's folks who didn't have all that support to do that. And I think 17 of those medical assistants have now gotten jobs working at central health and community care, bringing that economics back to their circles and their social networks. And now we're building pathways for community health workers. And we know there's also another part of this problem, which is that young woman needs a place to drop her kid off so she can study. Needs a place to get health care for herself, her children, maybe her mother and her aunties and her sisters. Can we put this together in a way that makes that easier, that acknowledges the connectivity, as you say? So we got to get the incentives right, who owns it, who can actually, that is our job, right? And we can do our job by connecting and then find the ways to break down those walls. I think it's a brilliant question. Thank you for asking it.
So Sarah, I think I've taken us 15 minutes past our conclusion time.
Yeah. We can continue. We have a reception in the adjacent room, so we can continue the conversation. I encourage you all to stay and have refreshments, and we can continue talking about this important topic. Thank you so much for your time and for being here.
Thank you.